Well, I appreciate you all coming out tonight, and Dottie, thank you for setting this up and the Cone Health Center. It's a privilege to be here, and I appreciate you all turning out for this, and hopefully this will be of some educational value. Just to kind of get an idea, how many people came to the seminar last year? Is there anybody here who came last year? Okay, a couple. So part of this talk may be a little bit of review for those who were here last year. For everybody else, hopefully it'll be something new. And then I'm going to highlight certainly some of the new changes that have also occurred over the past year. And really the objectives of the talk tonight are just to provide a little bit of general background information about prostate cancer, discuss how prostate cancer is diagnosed, discuss some of the controversies surrounding early detection and screening for prostate cancer. And then we'll discuss, when patients are diagnosed with prostate cancer, we now understand that there is a wide spectrum of risk associated with prostate cancer. Some prostate cancers are very slow growing, whereas others are very life-threatening and can progress very rapidly. And so we'll discuss a little bit of how we determine which men have more aggressive cancers and which do not, and how that affects our treatment. And then finally, should you consider routine screening for prostate cancer? And then certainly we'll take some questions at the end. Just some background information. Prostate cancer, no doubt, is a major public health problem in the United States. It's the most common cancer in men, with about 230,000 people expected to be diagnosed this year alone. It's also the second leading cause of cancer death for men in the United States. So when you hear that prostate cancer oftentimes can be a slow-growing disease and may not be that aggressive, that can be true, but we can see here that there's still many people who are dying of prostate cancer each year in this country. Risk factors for being diagnosed with prostate cancer are advanced age, family history, particularly a first-degree relative, so a father, brother, uncle, and then African American race is a risk factor for prostate cancer as well. There's about a 15% lifetime risk of being diagnosed with prostate cancer in this country, so that's about 1 out of 7 men. So you just look around the room here, and at least 2 or 3 folks would potentially be diagnosed with prostate cancer, just based on numbers alone. But there is only about a 3% risk of dying of prostate cancer, and that's about 1 out of 38 men, and as we'll see, there's multiple reasons for that. One of the major problems with prostate cancer is it's typically asymptomatic. Men don't really have symptoms until it's a more advanced stage, and at that point it's typically incurable. So it requires some sort of test for us to help diagnose it at an earlier stage when it can be potentially cured. And so that's the main point I would make here. There's usually no symptoms. When people ask me, well, I shouldn't have prostate cancer, I don't have any symptoms. Well, if you're having symptoms related to prostate cancer, it's typically a much more advanced situation and typically an incurable situation at that point. So most men who are diagnosed these days and are at least are candidates for cure are not going to have any symptoms. There's 2 main tests that we use to screen and diagnose prostate cancer. The prostate-specific antigen, or PSA blood test, which many of you may be familiar with, is a test that's been around for the last few decades. And then the digital rectal exam, or the dreaded finger exam, is the other way to detect prostate cancer. These 2 tests help us determine who's at high risk for having prostate cancer, and then the definitive test to figure out if cancer is present or not is to undergo a prostate biopsy. And this is an office procedure, so something we typically do in the office, performed by the urologist under a local anesthetic, just like if you went to the dentist and you had a dental procedure where they inject you with a medication and numb you up. Similar type idea. We do use an ultrasound probe that's placed into the rectum, so that's a lot of pressure, just like when you have the rectal exam in the office. And the ultrasound allows us to visualize and then direct the biopsy needles into the prostate. Overall, it tends to be a fairly well-tolerated procedure with a low risk of complications. I won't pretend to tell you everybody enjoys it. It's not something that most of my patients tell me, I can't wait to come back and do this again next week, but at the same time, it's typically pretty well tolerated. When somebody is diagnosed with prostate cancer, the next pieces of information that we want to know are the grade and the stage of the cancer. So grade of a cancer is an estimate of the aggressiveness or the aggressive nature of a particular cancer. The cancers that have higher grades tend to grow quicker and are more likely to spread. The stage of the cancer is an estimate of how advanced it is at that point in time. So you can have a low-grade cancer that's been around for a long time and might be more advanced, or you can have a very aggressive type cancer that's just begun but caught at a very early stage. Does that make sense? Okay. So the treatment recommendations then are based on these two factors, among others, but these are the two major factors that we typically are looking at. And as far as how we stage prostate cancer, usually stage 1 or stage 2 cancers refer to cancers that are localized within the prostate gland. These are typically cancers that are at a very curative stage. We then have locally advanced or stage 3 cancers that are typically cancers that have started to grow a little bit outside the prostate but are confined to that area. They haven't spread to other parts of the body yet. And then finally, cancers that might have spread to the lymph node areas or other parts of the body. The bone is a common place in prostate cancer. And these are stage 4 cancers. Those are typically not curable but treatable situations. The way we typically stage prostate cancer when men are first diagnosed is typically with the rectal exam. So if we feel a hard spot or a firm area on the prostate, that gives us an idea of how advanced it is. Many times these days with the PSA test, we won't feel anything on the prostate, which suggests a very early diagnosis. So most men don't need to undergo additional tests. That being said, for higher risk cancers, we sometimes will use bone scans or MRIs or CAT scans to also help us better determine whether there's a risk of cancer having spread to other parts of the body. So once a man is diagnosed, and say I diagnose a man with prostate cancer and he comes in to talk about it, one of the next steps is to try to determine where on the spectrum of cancers does he fit. Is he at this low risk end with a really slow growing early cancer that might not cause him a problem for a long, long time? Or does he have one of these very aggressive, life-threatening cancers that could cause him serious problems or death in the near future? And again, a very wide spectrum. There's a lot of ways that we do that, and it's become more sophisticated over time. But typically, we can use some of the information we just talked about, the stage, sometimes the PSA test itself and that number, and then the grade of the cancer, which are kind of the 3 primary factors that we'll oftentimes use to figure out where they fit on that spectrum. These days, we'll even use the number of biopsies. So typically, we take 12 biopsies. If we find it in just 1 biopsy, obviously that's a lot more favorable than if we find it in 11 or 12. The percentage of each of those biopsies, how much cancer is in each core that we take, and then using some other measurements such as something called PSA density, where we look at the size of the prostate in relationship to the PSA value. And we can use all this information now to really figure out who are the men that have these really slow growing, less aggressive cancers that maybe we don't have to be so aggressive about treating, and who are the men that do need aggressive treatment. And prostate cancer really is a slow progression in general compared to a lot of other cancers. It typically starts out as a precancerous lesion, or it's thought to, and then gradually progresses to a true cancer that's localized within the prostate and it's asymptomatic. So men, again, don't have any symptoms at that point in time. That is a very curable stage. So right here, when we're dealing with an asymptomatic and a localized cancer, this is the chance we have to cure prostate cancer. And then depending on the grade and the aggressiveness of that cancer, it will usually gradually progress to the point where it could develop into metastatic cancer, which is an incurable situation, spread to other parts of the body. And for some cancers, that might take even up to 10 or 20 years from the time it starts. So it makes the point a lot of these cancers can be pretty slow growing. Once the cancer is spread to other parts of the body, again, it's an incurable cancer, although it's still at the beginning may be asymptomatic, but ultimately those lesions in the body can progress to cause symptoms such as pain, a decline in quality of life, and eventually death. And obviously those are really the things we're trying to avoid for men. We want to prevent the symptoms from developing from metastatic cancer, and prostate cancer can be a very painful way to die for men. So that's what we want to avoid, and obviously death. So when I sit down with a man and we're talking about treatment for prostate cancer, there's a couple goals that we have. Number one is to provide good cancer control, and I use that term as opposed to cancer cure because we don't have to cure every single one of these cancers. If I have a 78-year-old guy who's had a couple heart attacks and he has one of these really low-risk cancers, he may never die or have problems from that prostate cancer, and he may have very good cancer control just by monitoring that cancer. Whereas I could take a 46-year-old healthy guy who has a really low-risk cancer, same type of cancer, but because he's going to live such a long time, that cancer is going to cause him a problem at some point. So that man might need to undergo aggressive treatment like surgery or radiation to prevent that from happening. So cancer control is our main goal, but a very close second goal is preserving a man's quality of life. And any of the treatments for prostate cancer can potentially impact urinary function, erectile function, and bowel function. And so these are things that we also have to take into account, and we're trying to walk the best balance we can between curing men or controlling that cancer, but also providing them a good quality of life. So the main issue here is we have a cancer that has a prolonged natural history, meaning from the time it starts, it can take a long time, sometimes decades, before it causes a man death or severe symptoms or problems. It's also more common in older men who might have other health problems. So when I sit down with a man and we're trying to discuss what options they have for managing their prostate cancer, the first question I'm always asking myself is, do I think this man is destined to die of prostate cancer, or is he more likely to die of other causes? And sometimes, obviously, that's a very difficult question to answer, and we do our best. Sometimes it's very obvious, those two examples I just gave you. More often than not, it's a very difficult question to answer. So that leads into the next discussion here, which is to talk about prostate cancer early detection and screening and the controversy out there. And I don't know if anybody's paid attention to the news over about the last 5 years, but you may turn on the news or open up a newspaper and see one day prostate cancer is a deadly disease, and you kind of read about some of these famous folks who have died and had a miserable death from prostate cancer, even at young ages. And you think, wow, that's a terrible, terrible disease. And then the next day, you open up the same newspaper, turn on the same news channel, and they're talking about how, well, most prostate cancers don't kill anybody, so it's nothing to worry about. And that gets very confusing. And I'll tell you, it gets confusing for a lot of physicians sometimes too. And the reason is there is this controversy, and I'll explain why. So if you go back maybe 20, 25 years ago, before we had this PSA blood test that we use these days, before that test, prostate cancer was very difficult to diagnose at a curable stage because, again, it doesn't have many symptoms, and so oftentimes it could only be picked up on a rectal exam, but sometimes those were more advanced cancers too. So we had about 25% of men who would walk in when they were diagnosed and already have metastatic cancer back in those days. Less than 50% of men who presented were even candidates to undergo curative therapy back then, and so we really needed a test, which turned out to be the PSA, at least initially here, to help us diagnose this disease at an earlier stage. So if we fast forward then, what happened as we started using the PSA test was we did see the death rates from prostate cancer go down quite significantly over the next 10 or 15 years. And in fact, they dropped from 1994 to 2004, they dropped about 40%, which is pretty impressive. However, it's hard to say that that was all due to PSA testing. And in fact, there were other countries at the same time, like the United Kingdom, who didn't routinely use PSA screening. They also saw a similar drop in the death rates of prostate cancer, and that might be due to the fact that over that period of time the treatments were getting better. There were probably some different environmental risk factors. People might have been taking different medications or drugs that might have reduced their risk, and so it's hard to tease all that out necessarily, although factoring all those things in, there have been good estimates that have been performed that suggest at least maybe about 50% of that reduction was due to early screening with the PSA test. And so what are we dealing with today? Well, if you fast forward now a couple decades to where we're at now, we now typically see about 85% of men who present with clinically localized cancers that are candidates for curative treatment. So as opposed to less than 50% now, the majority of men that we see are candidates for cure. Less than 4% of men now present with metastatic cancer. So it's a much smaller group that we see now of men who just walk in the office and they already have cancer that's spread to other parts of their body. And as we discussed, the mortality rates have certainly decreased. The problem is, because all that sounds really good, but the problem is there's been some collateral damage that's come along with that. And the problem is we have now a lot of cancers that have been overdiagnosed and overtreated. So if you go back again a couple decades, the pendulum was over here. We couldn't diagnose these cancers early enough. And you fast forward, this PSA test, we knew it could pick up these cancers early. Everybody thought this must be a great test, and the next thing you know, we were diagnosing all these cancers much earlier. But again, not having a full understanding back then as to how long some of these cancers took to progress and cause problems, we were probably diagnosing, and in retrospect, we were over-treating a lot of men who, knowing what we know now, probably didn't need to be treated because their cancer probably wouldn't have killed them. We just didn't know that back then. And we'll talk about the difference between overdiagnosis and overtreatment. I think that's an important distinction to make. So the dilemma we have now is we have this PSA test, which can detect prostate cancer at an early stage when it's most curable. However, since prostate cancer is a disease that is found in many men who are older, who might have other medical problems, many of these cancers may not be life-threatening. And so there's a risk of over-treating men if we're not careful. And so based on those concerns, the question is, by screening, are we doing more harm than good or more good than harm? And that's confusing. There's a controversy there. And there's actually different recommendations from various medical societies currently about screening for prostate cancer. So this is the question that we have to ask ourselves and try to answer. Are we doing more good than harm or more harm than good by screening the population as a whole? And how do you begin to answer this question? And I don't want to bore you all with a lot of statistics or anything tonight. I want to keep it pretty simple. But early on, there were some studies that were kind of lower level evidence studies where they basically went back and looked at populations of men in what we call retrospective or observational studies. And those studies were somewhat conflicting. They didn't really answer the question for us. In 2009, we had some of the best PSA screening studies that were initially reported and started to give us some insight into the answer to that question. The largest study that was done was a study of about 180,000 men in Europe, where they looked at men between ages 50 and 74, and they typically got a PSA alone, and if the PSA was over 3, they were recommended to undergo a prostate biopsy. And what I'll point out here is that of the men who were found to have a positive test, their PSA was elevated, about 86% of those men underwent a biopsy. So it was a pretty compliant group of people who were told you're at a high risk for prostate cancer. Most of them went ahead and had the test to find out if that was the case. And we'll see how that's different than some of the other studies here in a minute. In the end, what we found is there was an approximately 30% lower rate of death from prostate cancer in those men who underwent PSA testing versus those who did not, and about a 40% reduction in the rates of developing metastatic cancer that's spread. One of the other things that you always have to consider when you're talking about screening tests, though, is how many men do you have to screen to be able to save one life, and how many men do you actually have to treat for their cancer to save one life. And initially, when this study came out, and everybody said, well, that's great, we can decrease the rates of prostate cancer significantly with this test, one of the criticisms was when it was reported at about a 9-year follow-up, about 1,400 men would have to be tested to save one life. And you'd have to probably put men through radiation treatment or surgery, 48 men to save one life. And the question was, well, is that worth it for the other guys? And there was a lot of controversy about that. That being said, we know that those numbers are time specific, meaning as you get further along, so there was 9-year follow-up and now we have up to 13-year follow-up in these studies, we know that those numbers typically go down with time. And that makes sense. If you have a cancer that might take 15 or 20 years to kill you, well, at 9 years, maybe you don't have everybody who was ultimately going to develop it and die who's met that outcome, right? So you might not see the true benefit until later on down the road. And what we've seen, if you get out to 13-year follow-up now, that number that we had to screen went from 1,400 to about 780, and it's probably going to continue to go down. The number of men we'd need to treat went from 48 down to 27. So as we have men who might be younger and have longer life expectancies, you can see that it may make better sense to undergo screening, and that again, that balance between harm and benefit actually may be more in their favor the longer they're going to live. I know that's a little bit confusing. Does that make sense to everybody? Okay, we can go through that a little bit more later if it doesn't. The other largest study that was done was a trial right here in the United States, which was the prostate, lung, colorectal, and ovarian cancer screening trial. And this was a smaller trial than the European trial, but still pretty large trial, about 5,000 men, and these were also men of similar age, 55 to 74. So similar group of men, although a population in the United States, which compared to Europe, you're probably now including more of an African American population, so it might be more applicable to the United States here. One of the issues was that in the United States, unlike in Europe, we had already started adopting the PSA test for a lot of men who were seeing their primary care physicians. And so automatically, if you start off with a trial and you're already doing screening, you're going to have a lot of men who are already found to have prostate cancer, and they're already excluded from the trial. So now what you're dealing with is a group of men who actually might be at a lower risk for prostate cancer because they've already passed that initial screen. So we had a group of men here who might be at lower risk for developing prostate cancer, and that's important to understand. These men got pretty routine screening like we've done here in the United States for a long time. They got PSA tests every year, and they had rectal exams once a year. And the difference in this study was when they were found to have a positive screen, if they had a high PSA, for instance, they weren't necessarily told, well, you need to go have a biopsy and we're going to do that on the study. It was, well, here, you're at high risk for prostate cancer, take that information and do with it what you're going to. And ultimately, what happened, unlike the European trial where 86% of men underwent their biopsies, less than half the men in this trial actually went ahead and had a biopsy. So unfortunately, if you have a screening test and you're trying to decrease the death rates from a cancer, well, you can tell somebody you're at high risk for a cancer, but unless they have the test to diagnose it and ultimately undergo treatment, you're never going to see any benefit, right? So 30 to 40% of men here in this trial underwent a biopsy, which is lower than the other study. The other issue is in the control arm. Remember, again, in the United States, PSA screening was relatively common. In the United States here, about 52% of men who were in this control arm who were supposed to not get PSAs actually went across the street or went to their primary care physician and had a PSA because they were concerned about it, or it was just done as part of their routine blood testing. So what we have here then is we had a screening arm, the men who were supposed to be getting PSAs, who might look more like a control arm because they weren't getting their biopsies and potentially getting treated. You had a control arm that was a little bit closer to a screening arm because a lot of what we call PSA contamination, a lot of those men were getting that test when they shouldn't have been. And so automatically we're less likely to see a difference between those two groups. Not surprisingly, that's exactly what they found. And so when they updated the results, even after 13 years, there was still no difference in death rates from prostate cancer in these two groups of men. The authors admitted, though, in their conclusion that they basically said there's no mortality benefit or survival benefit for what they called organized annual screening, regular testing once a year, versus what they called opportunistic screening, men who were getting screened but maybe not as frequently. And so the one thing this told me was that maybe the way we're screening is not the best way to be screened. Maybe we could be doing it less frequently or less aggressively or not in every single man. The last kind of good trial, level 1 evidence trial that was done was there was a trial out of Sweden where they looked at younger men. This is men who are ages 50 to 64, so a younger group of men now. And remember, as we were talking earlier, the thought here is that younger men may benefit more from screening because they're going to live a longer time when prostate cancer could potentially cause them a problem. So these men either got a PSA every 2 years, and if it was over 3 or even over 2.5 in some areas, they would go ahead and recommend a biopsy. Only 3% of the men who were in that control arm and weren't supposed to get a PSA actually got one, so there's very little contamination here. This was a true screening trial, PSA versus no PSA. And 44%, there was a 44% lower risk in death rates of prostate cancer. So again, it showed us that PSA screening can potentially lower the death rates from prostate cancer. The number needed to screen and number needed to treat, remember those two important numbers there, were a lot lower in this trial with 14-year follow-up. The number needed to screen was 293, and you'd have to treat 12 men to save 1 life. And that's very similar to what we see in other cancers where screening is routinely recommended, such as breast cancer, for instance. So we have all this information, and what's come out of it? We were thinking these two trials, this will answer the question, well, no, should we be doing this or shouldn't we be doing this? Well, for a lot of the reasons that we just discussed, Again, you had all these different medical societies, and they all came out with different recommendations, some of them completely conflicting. From some recommending we shouldn't be using the PSA test anymore, to some others saying, well, we should be strongly considering it, but it should be a discussion between a physician and the patient. And in the end, we basically have a lot of confusion still, maybe more confusion than we did before these studies came out. So what are the actual facts we can take away from these studies? Well, number one, we now have 2 pretty good trials that have demonstrated that PSA screening can decrease the death rates from prostate cancer. So we know that. There's not a lot of argument there. However, we know that PSA screening can lead to an increased diagnosis of prostate cancer, which again, potentially can lead to an overdiagnosis and overtreatment. If we're finding a lot of these low-risk cancers that are ultimately not going to be life-threatening for a man, if those cancers get treated, we're going to overtreat men, and that's a man who might have otherwise been able to live his life out, not taking on any risk with his urinary function or sexual function without having to worry about dying of prostate cancer. So there is that risk. And I think we can safely say now we should not be routinely performing PSA testing in men who have a 10-year life expectancy or less. Even the studies that have demonstrated that there's a benefit and there's a reduction in death rates, we don't really see those until at least 10 years out. So this is not a test that's going to help us find a cancer that's going to kill a man in 5 years, but 10 years, 15 years, 20 years, it very well may. And this current data also really doesn't tell us a whole lot about men who have longer life expectancies. So none of these studies have enough follow-up to know what happens at 15 years, 20 years, 25 years. So when you talk to a 50-year-old guy and you counsel them, you have to be careful because this data may not apply to them at least for their entire lifespan. So what are our options now for screening? What do we do now? Well, again, some folks have advocated just getting rid of the PSA test altogether. Well, the problem with that is then we go back 20 or 25 years ago when we had more men being diagnosed with incurable cancers, a higher death rate of prostate cancer, and we had less than half of men who were even candidates for cure. The other option is we can continue just current routine screening. Every man gets a PSA when you get your physical with your primary care doc. The problem there is, again, we're going to have this overdiagnosis and overtreatment problem. Or we could do, which to me makes the most sense, is try to improve upon what we've learned and try and do a better job with screening since we now have more knowledge to figure out how to do it and do it right, or at least better. And so how could we use PSA better today? Well, number one is screening more selectively. We know that men who are younger have longer life expectancies. They probably are the ones who have the most to gain from screening. We can screen less frequently. The American trial showed us that screening every year in every man probably is no better than if we screened less frequently and maybe in less men. Using the PSA better. I don't today just look at the PSA number and if it's above a certain number or below a certain number, that doesn't determine whether I do a biopsy on a man or recommend a biopsy to a man. I also look at the change. So if I've got a gentleman whose PSA has been 1 for years and years and years, and now it jumps up to 2.5, I'm a lot more worried about that man than I am a guy whose PSA has been 4 for 8 years and has an enlarged prostate and it's not changing at all. So sometimes those changes in the PSA can be more important than the actual number. And then also the use of some additional tests. There are some newer tests that have been approved and we're still trying to figure out exactly how best to use them. But I can foresee in the future us getting to a point where if a man has an elevated PSA, that might be the first screening test, and then from there we take that high risk of men and we might do another test to determine if they really need to go through a biopsy rather than jumping straight to a biopsy. Because on the other side here you can see one of the things we need to do is reduce the amount of unnecessary biopsies. Right now prostate cancer can only be diagnosed doing a biopsy, and there's a lot of men who undergo a biopsy who don't have cancer, so if we can reduce the number of unnecessary biopsies, that would be helpful. We can improve the side effect profile of treatments. If surgery or radiation therapy or a lot of the treatments we have for prostate cancer had no side effects, well, there wouldn't be much controversy here because we could cure the cancers, men could maintain their quality of life, no problem. So we've got to continue to work on improving the treatments as well. And then finally, active surveillance. And I'm going to talk about this concept a little bit more because I think there's a lot of physicians who sometimes feel uneasy about this, and I think there's a lot of patients who feel uneasy when we first bring it up. but when we discuss it, it usually makes better sense. A lot of men will readily accept that concept, and I'll explain what that is here in a minute. As far as improving the biopsies, what can we do? Well, again, reducing the number of unnecessary biopsies, we talked about that. There's also a lot of new technology coming out looking at using imaging to help direct prostate biopsies. Prostate cancer is probably about the only cancer where we go ahead and we biopsy the prostate, but we're not biopsying a lesion that we can see. We're usually just systematically sampling the entire prostate. So most cancers, if there's a spot on the kidney or there's a spot in the lung, they're usually using some sort of imaging to direct the needle into that spot, right? With prostate cancer, we've never had that. Part of it is there's not ever been any good imaging tests that can help us to do that and do that accurately. More recently, there has been some technology developed using MRI to help us be able to do that. And I think this is probably something that over the next few years is going to become part of the standard way that we diagnose prostate cancer. And there was a recent study that showed we can potentially increase our rates of detecting the high risk, the worrisome cancers by about 30%, and we might be able to decrease the diagnosis of these kind of low risk cancers that don't cause problems by about 17%. So that was a pretty impressive study. So I think we'll be using more imaging with prostate cancer like we do with a lot of other cancers as the years go by here. Reducing the risk of infection with biopsies. All across the United States, there's been an increasing rate of antibiotic resistance, as many of you may be aware of. And so if you look at big kind of national databases or groups of men, there's about a 4 to 5% risk of having an infection after a prostate biopsy. How do you decrease that? And that's been increasing over the last decade or two, probably because we have used antibiotics pretty indiscriminately in this country and overused them a lot. Well, one way, and what we do in our office, for instance, is we identify high-risk patients up front. So we look at patients who have either worked in or near a hospital, patients who have traveled internationally, or patients who have been on certain antibiotics over the past 6 months before their biopsy. We know those men are more likely to have different types of bacteria that might put them at risk for infection if we just use kind of standard antibiotics. So for those men, we'll use a different antibiotic regimen, and our rates are a little less than 1%. Targeted antibiotic prophylaxis. So there are some folks who are basically doing what we call rectal swabs, where a patient will come in a week or two before their biopsy and they have a sample of the bacteria from the rectum taken, it's cultured out, and then the antibiotics are directed to that specific bacteria. That can certainly, and it has been shown to lower the rates of infection. It is a little bit of an inconvenience, obviously, for patients to have to come in an extra time, but again, in the end, if it avoids an infection, it might be well worth it. And then finally, the use of more aggressive or combination antibiotics. And the problem with that is that just continues down the road of eventually developing resistance to those antibiotics. So some people have advocated that, but I have a little bit of concern that that might just lead to more resistance. Same problem we're having now. As we discussed, improving the treatments. Any of the treatments, if we can get our treatments to the point where they don't have much in the way of side effects, well, again, a lot of this controversy goes away. There'd be a lot of men who wouldn't be so worried about undergoing screening or being diagnosed with prostate cancer because they'd have less to lose if they underwent treatment. And again, this idea of active surveillance. So when we talked at the beginning, we said there was about 230,000 men who will be diagnosed with prostate cancer this year. And then we said there's about 28,000 men who will die of prostate cancer this year. That means there's a lot of men who are diagnosed but aren't dying, right? Question is, why is that? Well, part of that is probably better treatment. Okay, so we are doing a better job of treating these prostate cancers and keeping men from dying. But the other issue is, again, a lot of these cancers are not life-threatening cancers. And so the concern always about screening has been if we find all these cancers, well, then they're all going to get treated, and a lot of men get treatment that can cause them side effects and they didn't need it in the first place. Well, what if we could, when a man's diagnosed, select out those men who really need treatment and avoid it in those who don't? And that's the concept of active surveillance. And that's something that we've really incorporated over the last 5 to 10 years in practice to try and, again, reduce that over-treatment problem. So many of you may have heard most people die with prostate cancer, not from prostate cancer. And again, that's true for a lot of cancers. It's partly due, as we talked about, from improvements in earlier detection and the treatments. Although, again, a lot of these cancers are just truly not life-threatening necessarily. The whole concept here is rather than putting a man through a treatment, okay, through a curative treatment, this is the idea of monitoring the cancer closely by following their PSA levels, their rectal exams, and repeating biopsies periodically to make sure the cancer is not progressing. So it's very different. Many of you may have heard the term watchful waiting. Watchful waiting implies that if you're diagnosed with a cancer, then we're not going to do anything about it unless a man develops a symptom or pain or problem, okay? We're waiting till it gets to an incurable stage, basically. Active surveillance is closely monitoring the cancer with the idea of still jumping in and providing a cure if it's needed, but only when we think it's really needed. So if you have a cancer, if a man's diagnosed at age 60, and that cancer is going to spread outside the prostate and become incurable on his 68th birthday, well, what I would tell men is, hey, let me meet you the day before your 68th birthday, and let's go ahead and take care of your prostate cancer then, with the idea of having those 8 years before you need treatment of good quality of life where you're not taking any risk. And that's ultimately what we're trying to do. Obviously, we can't do it, that perfectly. So by monitoring these cancers, we still want to have the ability to cure the cancer. It's not just waiting until it's spread. For younger men, I tell them it should be thought of as surveillance with delayed treatment. So if I've got a 50-year-old guy and he says, well, boy, I really don't want to go through surgery and maybe I'm single, I'm worried about my erectile function. Well, that man may want to hold off on doing anything about his prostate cancer and probably can safely do that if he's got one of these low-risk cancers. But he's young enough, he's probably going to have to do something at some point. And so those men, I tell them, number one, I want you to be compliant with your follow-up and make sure you're coming back for your appointments because we don't want to miss something here. And you have to be prepared that we are probably going to have to do something someday down the road. As far as who we should offer active surveillance to, that's still an evolution. We're still trying to figure that out, but it's clear it's not an option for everyone. Typically, we are looking at men who have low-risk cancers, these men with lower grade, smaller volume cancers, lower stage cancers like we were discussing, or men who have shorter life expectancies, may have other medical problems, and they're not going to live that long. So if I have a cancer that's going to kill a man in 8 years, but because of his other medical problems, he's probably only going to live 5 years, again, active surveillance may make good sense for that man. But if I've got a guy who has a cancer that's going to cause him a problem in 12 years, but he's going to live 15 years, probably not a good candidate for active surveillance. So the advantages of this approach are that it avoids or at least can postpone a lot of the side effects of treatment, erectile dysfunction, urinary problems, bowel problems that can happen. The disadvantage is there's currently no perfect way to predict which cancers are not life-threatening. And so if we undergo surveillance, men have to understand there is always a small risk that this cancer could progress at some point and it could get to an incurable stage even while we're monitoring it. Usually that risk is pretty low, but there's always that risk or chance for a missed opportunity for cure. And some patients also experience a lot more anxiety living with an untreated cancer. I think that last sentence, I think that has more to do with how patients are counseled, because when I sit down with most men, although I'll have some who are very skittish at first, and oftentimes it's their wives or their spouses who maybe have more concern, most men eventually, once they understand everything we're talking about here, realize, hey, I am probably better off just monitoring my cancer as opposed to going through aggressive treatment, or at least it's something I ought to consider here. Patient selection, so again, the low-risk patients, there's a lot of factors that we use in trying to select who those men are. So we want men who have these low-grade cancers, typically a PSA less than 10. Their stage, it should be a confined cancer. And then these days we even look at, again, the percentage of cancer that's involved with each biopsy that we take, how many of the biopsies are positive, and then this concept of PSA density, how high the PSA is compared to the volume of the prostate. And those have all been shown to be very predictive for selecting out the smaller, non-aggressive, non-life-threatening cancers. How do we perform active surveillance? Typically, it's a PSA and a rectal exam at least about every 6 months or so, and then typically we repeat biopsies every 1 to 2 years, depending on whether there's any factors that concern us in the interim. So if I've got a guy and we said, well, let's do your next biopsy in 2 years, but 1 year down the road his rectal exam changes or his PSA goes up, we might do it sooner, right? We're also using MRI for these patients more often now, and that's become incorporated, not standard yet, but I have started using it for all my active surveillance patients. I think it helps us to make sure we're not missing something when we make an initial diagnosis. And there are some newer molecular tests now where you can take the biopsy information, we can take that tissue, and we can run some tests on it that look on a molecular level to help better determine what the aggressiveness of that particular cancer is. And so all these other factors that we've talked about are not perfect in determining who the best patients are to watch their cancer versus treat them. These tests, at least early on here, have seemed to be able to help us do a little bit of a better job. And I think we're going to have more and more tests like this where we can sit down with a man right when they're diagnosed and tell them, you have the type of cancer that's not going to cause you a problem for 20, 25 years. And you know what? You're 70 years old right now, you've got diabetes, high blood pressure, and have had a heart attack. Realistically, that cancer is never going to kill you. Hopefully we can get to that point. Indications for intervention. So how do we decide when to stop surveillance and start treating men? Well, if we do a biopsy and we find that the grade is now higher, so the grade's changed. If there's more of the cancer, if the PSA rises, although PSA has not been shown to be a perfect test to help us determine progression of cancer, and then finally psychological distress. Some men, again, if they're just too anxious, they can't handle it, we can always change our approach and treat them. The problem traditionally has been physician and patient acceptance, and I think now, again, we're getting more and more comfortable with this concept. We have a better understanding of which cancers are going to progress and which are not. Ultimately, we need a better test. Okay, so you've seen a lot of information here. PSA is not a perfect test. If it was, it would only find the patients we really needed to find with not just prostate cancer, but those aggressive kind of prostate cancers. And if we can have a better test that can not only tell us when cancer is present, but when these high-risk cancers are present, that's what we're looking for, and we're getting there. And so ultimately, aside from getting a better test, we want better biopsy strategies. We want to use active surveillance a little bit better, probably more frequently than it's currently used in this country. We want to improve our current treatments to decrease the risks again, and hopefully even develop new treatments for men who might have less aggressive cancers that don't require very aggressive treatments. So what should you do? Well, number one is what you're doing right now is becoming more educated about prostate cancer. This gets all these issues are really confusing. They're confusing for a lot of physicians who don't dedicate their career to it. This is all I do. So, you know, it can sometimes be confusing when I talk to people about it because there are so many moving pieces here. But by sitting down and kind of becoming educated about prostate cancer, that's probably the most important thing you can do to determine should you be screened or not. You need to understand the risks, you need to understand the benefits. I think we can safely say if you have less than a 10-year life expectancy, routine screening probably isn't going to be beneficial to you with PSA testing. And in this country, on average, a man reaches that point when they're about age 75. So usually if I have a guy in average health who comes to me at 75 and he says, should I get this PSA test? I'll tell him it's probably not going to be helpful to you because the data shows it can reduce the risk of dying of prostate cancer, but it's going to take about 10 years to see that benefit. And that guy's probably not going to live long enough to see that benefit. A greater than 10-year life expectancy, I would consider routine prostate cancer screening. But again, you have to understand the pros and cons, like we're discussing tonight. And I always recommend talk with your primary care doctor, get their opinion. Usually they're the ones who know you best and can help you figure out, is that a good idea for me, based on my health, based on my age, based on my life expectancy. And this is not an age-only issue. Age is a number, I always tell patients, but I'll have patients who come in and they're 75, but both their parents are still living. And I always tell folks that one other indication that makes it appropriate to get screened for prostate cancer, if you walk in and see me and your parents are still alive, I don't care how old you are, you're probably going to live a long time too. So getting screened is an option depending on your life expectancy. It's not just because your age. greater than 20-year life expectancy. These are men who probably can derive even more of a benefit because they're going to live long enough that even some of the less aggressive cancers could be a real issue for them. And then finally, most importantly, the men we should be screening are men who have risk factors for prostate cancer, men who have a first-degree relative, father, brother, uncle, African-American men who are at a higher risk for prostate cancer. These are the men who we really need to be testing because these are the men who are at the highest risk. And so I think if we focus our efforts a little bit better with screening, we'll probably do a better job in this country of avoiding that overtreatment problem, but still helping to reduce the death rates of prostate cancer, which is ultimately what we're trying to accomplish. Just to make a quick plug, and then I'll take questions, the Zero Prostate Cancer Run and Walk, which we had the first one last year here in Greensboro, which was really successful. We raised a lot of money for prostate cancer care that's going to stay here in the community and help us do some of our screenings and provide better care for patients. This year it's going to be on November 21st, which is the Saturday before Thanksgiving. Anybody's welcome to come out. We'd certainly encourage you, and hopefully it'll be warmer than it was last year. I don't know if anybody was there last year. It was a little chilly. But it's a great event. It was a lot of fun, and again, all for a good cause. Thank you.